Alright, hi folks, it's me. I wanted to make this quick video to address some of the important questions that had come up in response to my end of the day case number 2, which was combined with the Patriots Parade, in which I talked about a surgical case that I did, and a number of good comments and discussion ensued, and a lot of you also kind of approached me personally, direct messaging me and asking questions about the case. And basically as a whole, the case was the question that I was posing everyone was the idea of when you have an endodontic infection that's combined with a cystic lesion, in this particular case a nasopalatine duct cyst that was in the area, and of course the cyst had become infected, and the source of the infection was the endodontic disease. The patient had developed an infection prior to the surgery, had swelling, and was put on antibiotics in order to address the severe pain that she had. And then the question at this point was, would addressing the source of the infection, the cyst, being the apicoectomy that was required to address the endodontic infection, suffice, or is the removal of this particular cyst from a parallel approach and then the required potential grafting and membrane placement would be absolutely required and necessary? So what I was trying to bring up as a discussion point is that doing this as a more minimally invasive first approach by going in there and addressing the source of the infection and the cyst, which was the endodontic infection. As you could see from the periapical radiograph, a lateral lesion was present. This was an old root canal prior to placing a recent post in there, and of course the post was not placed under a rubber dam, which itself is a major source of contamination. There is space between the post and the gutta percha and other potential foci of infection growth. The source of the infection of the cyst was in fact a tooth. So many of you had said this is a nasopalatine duct cyst alone and should have only been removed. Unfortunately, this is one of those lines of thinking where you only treat the radiograph and you don't think about the etiology of the disease here, which is the bacteria that was inside the tooth. Just removing the cyst alone from a parallel approach and grafting it is the kind of thing that we used to do many years ago when we didn't really understand the source of infection. And in this particular case, the source of the infection in the cyst is the bacteria inside the tooth, which without its proper addressing will cause a recurrent problem. And oftentimes you see many of our colleagues go in there around teeth that have endodontic infections, curette out the infection and place bone grafts only to see it fail, not understanding that the source, which is the bacteria inside the tooth, has to be addressed for the so-called periodontal lesion to heal. So grafting and removal in itself is just a mere act of addressing a symptom without addressing the source, which is the bacteria inside the root. In this particular case, the apicoectomy was required to address that source, which you could see from also a lateral lesion that was present in this tooth, as well as the apical lesion that was draining right into the cyst. Now, the way I was asking the question was, will this approach alone be enough to, in a sense, kind of marsupialize the cyst? That, by the way, the biopsy report came back as granulation tissue with some epithelial linings, which of course the epithelial lining is related to the cyst that is present in this area. My question was, perhaps this more minimally invasive approach without the requirement for removal of the paddle graft, and in a sense this kind of a pseudo marsupialization process of curating out the lesion from inside that small hole from a buccal aspect, could that potentially be enough? Of course, none of us really know, and from my search of the literature for nasopalatine duct cysts, its total removal versus marsupialization have both been proposed, and there really are no specific clinical controlled trials to follow up these cases to find out whether one approach of marsupialization versus just removal versus this approach of removing the source is adequate. So in this particular case, with proper follow-up, you are able to create a more minimally invasive approach first, with the understanding and the communication with the patient that a potential follow-up with the surgical intervention on the palatal side, once the source is now taken care of on the on the apical side may be necessary, which is certainly true, because that procedure may have been done. Now, whether it's done on the same visit or a separate visit, that's two separate ideas, because in this particular case, with these procedures, I hardly ever give a paddle injection. Most of these types of surgeries on the buccal aspect of the teeth do not require a paddle injection. That anesthesia for these types of surgeries is itself a whole big area that, of course, I'm very passionate about. I do teach the advanced anesthesia course, and anesthesia is a big part of this whole thing. And of course, at some point in the future, hopefully I can get into. By the way, one thing I was going to say is that I'm thinking of doing these end of the day cases and create the discussion, and then perhaps follow up the case with a live type of a Q&A session. And if you think that would be something that you might be interested in, maybe we can kind of arrange that I can do a live type of a video to follow up these end of the day cases, which a lot of you guys have apparently liked. You've emailed me quite a bit, so I'll try to do more of them. Anyway, this is a little video response to end of the day case number 2, and if any other questions come up, don't forget to contact me. Bye bye.